Okay, I think looks like we still have a few people coming in, but I will go ahead and get started. So I want to welcome everyone to this kickoff meeting this afternoon with some exciting work that we've been looking forward to. And many of you who are joining us today, I know, have been talking with us about this work that we have coming ahead and what are some of our goals coming out of the work that we're going to be doing with the National Center for START Services. And today we're joined by Dr. Joan Beasley and Ann Klein, who are going to sort of talk us through what the process will be for this community service system evaluation that they're going to help us with. I know from speaking with many of you since I have been here in this position that we are clear that we have some concerns and we have some real needs in our service system around supporting individuals with behavioral health support needs. And so we're looking forward to this work with National Center for START Services to kind of get us on a path to understand what our system is doing well, what are some of the gaps and what are some of the needs in our system, and more importantly, what are the recommendations that we can have and will come out of this evaluation to help us then hopefully in turn take on a project to improve our service system. So with that, I will turn it over to Dr. Joan Beasley. Thanks for joining us this afternoon.
Hi, thanks very much. And it's wonderful to see there are 142 people here today who are interested in this project, which of course we think is a very important project. What we're going to do today is review the process that we use to evaluate your community service system, and then talk a little bit about what you can do to help us as we move forward. I'm hoping that the reporting meeting, the meeting that we have at the end of this process, which takes about 6 months to complete, will occur in person in Maine so that we can really roll up our sleeves and kind of come up with a strategic plan together as a group. So can I see the first slide, please? So I'm a member of the START team. I'm actually the founding member of the START team. And everything that we do in this evaluation has some foundational principles based on what we have learned from START. So I'm going to give you a very quick overview of the START model and what it means. START, by the way, is housed just down the street from Maine in New Hampshire. And the model stands for Systemic Therapeutic Assessment, Resources, and Treatment. And what we're talking about is systemic therapeutic, systemic assessment, systemic resources, and systemic treatment, meaning that the START model is a whole person approach and understands that things happen for people, all people, including people with disabilities, in the context of their system of support, in the people in their lives, in the opportunities that they have. And START is an evidence-based model of community-based crisis prevention and intervention services. And the programs serve people ages 6 and older who have intellectual and developmental disabilities, including who are autistic and mental health needs. START was first developed in Massachusetts by me. I'm sitting here in my basement in Brookline, Massachusetts, in 1988. So it's one of my 3 children. I had START I had my daughter in 1987, START in 1988, and my son in 1990. So my children in their entire lives have had a sibling called START. The model was cited as a national program to overcome disparities, health disparities for people with IDD back in 2002 in David Satcher's Surgeon General's report. It's been well researched, and it is the most researched model of its kind in the world. So we have a very large database, and we evaluate continuously because we're not just evidence-based, but we're evidence-informed, which means every START program introduces new concepts and ideas through the work. And what we do is look at the data and we modify as we go to improve our practices. And the other thing we really focus on is that people with lived experiences have the greatest expertise about what they need and want, and that we should not try to manage them, but engage them in the process of promoting their own health. So the Center for START Services is at UNH at the Institute on Disability, and it's made up of experts from around the country who have done this work in MHIDD and also have been involved in the development of START programs over the years. Bob Schultz, who is somebody that some of you know in Maine, who's been working with you, was one of the original members of the first START teams back in 1988. So we're like the Hotel California, you can't leave. I don't know if people know it. I wonder how you can sign whether people know the Eagles song. You're going to do that. All right. Next slide, please. Next slide, please. Okay. So here we go, systemic therapeutic. That refers to both the whole person approach and the context, as I said earlier. Next slide. Systemic therapeutic assessment, meaning that all the assessments are within the context of the whole person approach and the system as a whole, and we attend to social contributors, assessment of treatment, diagnosis, and other historical contributors. How we are doing, not just what we are doing, is very, very important. Systemic therapeutic resources are resources to address the entire context of the person and their life experience to promote effective treatment. And so some of what we'll be exploring in this analysis is actual life experiences. We will interview a number of family caregivers about their experiences with the mental health and other service systems to kind of get a sense of the context in which their family member is experiencing benefits or lack of benefits from mental health care. Mental health resources should go beyond medication and include all the available approaches that are adapted to meet the needs of people with IDD. So one of the things that we see is a lot of rejection of people with autism and intellectual and other developmental disabilities. And that rejection is attributed to the idea that if you have a developmental issue, you cannot benefit from mental health care. That would be like saying if you had a developmental issue, you could not benefit from dentistry or gynecology or cancer treatment or heart disease treatment. It's absurd. And it's something that we spend a lot of time sort of focusing on the absurdity of that and trying to get people to engage in a common understanding. I love what absurd looks like. I'm going to make her do that again. Absurd. It's absurd. There you go. All right, next slide. And then finally, systemic therapeutic treatment. It's one thing to kind of understand the whole person and then to focus on one treatment approach like behavior management or medication, because that's all you've got in your toolbox. If you're really going to think about systemic therapeutic assessment and resources, the treatment has to follow, and plans have to be a byproduct of those assessments and resources as just described. In order to have a comprehensive plan, all conditions must be met. And again, we ask very specific questions. We have focus groups, we have a survey to really kind of cut through all of that and see what is it that we have available in terms of resources and how does that contribute to the mental health and well-being of the citizens of Maine. Next slide. So what we're really trying to build in every state, in every county, in every city, in every town, everywhere, is what we call a tertiary care approach. This is a public health model based on the work of the World Health Association. And basically what you see is that there are 3 levels of intervention that any system of care, whether it's mental health care, primary health care, habilitative services, support services, have to keep in mind. The first level, primary intervention, is that which builds capacity so that people don't need services and supports, that they can manage the challenges that they face in their health and in their disability, and change the odds from needing more intense services and treatment. And that comes from building capacity and understanding across the board. So just as an example, if you have a child who has been rejected because of they're autistic in their school setting and is placed in a segregated school, and the family is taught that the child will never be able to have an ordinary life, and that they need to have interventions to change the way they are neurologically. In other words, the rejection of their autistic features as being disabling, rather than the acceptance of their autistic features as being something that should be accommodated and incorporated into the way you approach the child, their primary capacity will be undermined. And this will be a lifelong journey to overcome that. If we can, with the 6-year-olds and 5-year-olds that we support, really get people to think differently about a child who's autistic, the family, the individual, and the school will have the capacity to change the odds from needing more specialized services. Secondary intervention, which we call beating the odds, are specialty services that are required when primary intervention is not enough, or whether those who provide primary intervention, ordinary caregiving, need more support and information and assessment. In secondary intervention, we beat the odds and we try to take whatever we learn from those assessments and push it up to primary to build capacity to not need those specialists for the rest of your life. So an example of secondary intervention would be outpatient mental health treatment, psychotherapy. If you have IDD, either you don't get access to this care, or in some cases, people are in outpatient therapy under the guise of anger management for 20 years. That is not good secondary intervention. If you're in anger management therapy for 20 years and you're still angry, then something is wrong with that intervention. It does not allow you to stop being and having needs-based relationships and move towards strength-based relationships with the treatment. So in our evaluation, we're going to be looking at not only are these interventions available, but are they doing what they should be doing, which is building capacity toward that primary intervention, changing of the odds. And then the third is facing the odds through tertiary intervention. That is 24-hour crisis backup, any kind of first response services. Every system of care needs 24-hour mental health support backup. I know, for example, that around the country right now, we have the suicide hotline, the 988 emergency hotline. We have been asked in several states to provide a course to train 988 responders to understand and be able to engage with somebody who's autistic or has a developmental issue when they contact the hotline, the suicide hotline. Tertiary intervention has to appropriately match the needs and accommodate the issues that our individuals face. And that means that training is part of that intervention. So one of the things we'll be looking at is, do we have these emergency services, and are they effective? Are they doing what they're supposed to be doing? Do people know what they're doing? Do they respond in a timely fashion, et cetera? The goal always in every system, every public health system, is to push the potential impact of the intervention up to primary so that you don't need as much secondary or tertiary intervention. And notice, one of the big reasons for that is when you're at tertiary level, the choices you have and resources available are limited. If you're going to go to an emergency room because you have a challenging behavior, the odds of being restrained and medicated are very high. They don't have a lot of choices. If you have challenging behavior in primary intervention, there's many, many more options available to support an individual to cope and to better address that issue. So that's why we need to go up to primary intervention whenever possible. Next slide. So why do a systems analysis when considering START? So our conversation with the state of Maine was, is START a program that should be developed in Maine? And my answer was, I really don't know. Because one of the things we need to do is see if we have goodness of fit. Does our mission match what you're looking for? We need to make sure that if you have resources available that can be adopted and adapted based on what we learned from the analysis, that we don't bring in START to duplicate what you already have that's going well. And we need to do this analysis because if we decide to go forward, whether with START or another remedy, everyone needs to have a role in the solution. It can't be the state's going to do this or the provider's going to do this or UNH is going to do this. It's got to be all of us together doing this in collaboration. Why consider the START model? And think about whether this makes sense for you, because we are a fidelity-based model, which means we have rules, guidelines, and expectations. And that is not for everyone. Not every state likes rules, guidelines, and expectations. So we need to make sure that that's okay with you. And it doesn't mean that the rules, guidelines, and expectations shouldn't be modified to meet the needs of Maine. But our evidence-based practices have standards that that are required in order to be a START program. And we really need to say this, analysis reflects our mission, and really we want to do better by knowing more before engaging with any system of care in helping them to improve outcomes. Next slide. So our mission is effective services and supports. Next slide. That there are 3 A's in the conceptual framework to define effectiveness, access, appropriateness, and accountability. Next slide. So we are going to be looking at access. So do you have access to what you need? Or is it driven by something else, like resources? So here is this patient who is trying to access something with their doctor, and the doctor's response is that what's defining how I'm going to treat you is defined by, unfortunately, you have what we call no insurance, and that becomes the diagnostic criteria, and that's pretty bad. Next slide. The next measure is appropriateness. So here's Timmy, he's drowning. He's asking Lassie for help. Lassie get help. Lassie did get help. Lassie got psychotherapy in response to Timmy drowning. That really wasn't the kind of help that Timmy was looking for. So the help that you get has to actually match the urgent need that you have. And I think this is a funny comic. I hope you're all chuckling to yourselves. The ASL lady isn't chuckling because she's interpreting. Okay, let's go, Julie. Next slide. She's smiling. Okay, and the third is appropriateness. This is one of my favorite cartoons from the New Yorker. It is one jurist talking to the other while somebody's testifying. And it says, I don't listen to the evidence. I like to make up my own mind, which is a big problem in many of the systems that we work, where people have a preconceived not understanding of what they think should happen, and there's no accountability to what's happening right in front of them. So the third A is accountability, and really understanding that you have to listen in order to lead, and you have to lead based on what you're listening to. And therefore, you cannot make up your own mind. You have to collaborate and join. So one of the things that we'll be looking for is there systems accountability? Do people believe that when they ask for something, they are heard, they are respected, and they get what matches their need? Next slide. So I'm going to pass this on to my colleague, Ann Klein, who actually does all the work. I look forward to the Q&A. I'm assuming there'll be chat or Q&A afterwards. Yes, Anne is saying yes. See, she does all the work. She knows what's going on. All righty. Thank you very much for your time. I look forward to our discussion.
Hi, everyone. My name is Anne Klein, and I am the project manager for this evaluation. So what I'm really going to talk about is the logistics of data collection, how we're going to do it, and how we are very much hoping all of you will assist us in this effort. So we can move to the next slide. So the evaluation has two primary aims. The first is to evaluate what is currently in place in the state of Maine and how well it's working in addressing the needs of individuals with IDD-MH. And when we're looking at what's in place, we're going to be looking for things that are working really well in the system, as well as places where things might not be working as well or where there are actual gaps in the system. And then we're going to learn from all of you how we think the existing service delivery system can be enhanced to improve services and supports. So those are kind of the broad aims of the evaluation that we'll be doing. Next slide. So this is a formal evaluation of the IDD-MH community. And what that means is that following the data collection and the analysis is that we're going to come back with a report that will go first to the folks from the state and then to all of you in the follow-up meeting that Dr. Beasley referenced. And that report will include recommendations for improving the effectiveness of services for individuals with IDD and mental health. And part of what we really want to do as part of this evaluation is to get all of you and the systems that you support engaged and collaborating in the recommendations. So this really isn't a situation where we come in and tell you what we think you should do. We're really coming in and we're asking for all of you to give input on what you think needs to happen and what needs to change. And we'll talk a little bit about the methods for that coming up. So next slide. So we have four primary methods that we're going to use to learn about experience with the service system and to create those opportunities for feedback. The first is an online survey of stakeholders, and that is a very broad survey that will go out to everyone and anyone we can think of who has any involvement with folks with IDD-MH. So everyone, and we'll talk a little bit about this more, but everyone from the IDD community, the mental health community, the education, the juvenile justice or the justice community, we're going to do that as broadly as we can. The second is a series of focus groups with key stakeholders across the system. The third is a telephonic family caregiver interview. We really want to make sure that users of the system, so folks with lived experiences and family caregivers, have lots of opportunity to weigh in. So we will try to interview families across the state about their specific experiences with the mental health system. And then the fourth is a Medicaid claims data review, where we will look at some of the claims data currently being spent on mental health services for this population and make some recommendations around how and what is being spent. So the resulting analysis is a combination of all of these data collection methods using both qualitative and quantitative data analysis methods. Next slide. Okay, so your role. So the online survey link will come out in an email to all of you. And your role is simply to complete the survey when it arrives and to distribute that same survey link to everyone on your contact list. So for example, if you work for a provider agency, sending it out to all your employees. If you work for a provider organization, sending it out to all your partners or colleagues or fellow agencies. We will provide drafts, like sample emails that you can use, but it needs to come from people within the state of Maine. So if any of you get an email from Ann Klein at University of New Hampshire saying, click on this link, you'd all be crazy to do it. Nobody's going to click on that. So it really needs to be personal from people within the system to other people in the system saying, hey, here's what we're doing. Take a few minutes, complete this survey. We would also encourage people to post the link to the survey on social media, if you have listservs or websites, so that it's really accessible to as many people as possible within the system. Next slide. Focus groups. So focus groups are with specific cohort groups. And what we mean by that is we want to meet with IDD providers as a group. We want to meet with mental health providers as a group. We want to meet with people with lived experiences as a group. So we get their unique individual perspective on the system. So they're self-identified groups, and the focus groups focus on two open-ended questions. How well is the current system meeting the needs? And what would you change or add to the system to better support mental health service needs? And one of the things that I would ask all of you to do today is in the agenda that you received as part of the invitation, there is a link to a Qualtrics survey that just asks for your contact information. And it also just asks if you're interested in participating in a focus group. And you'll have plenty of opportunities to kind of reach out if you want to be part of a focus group, but that's an easy way to just make sure that you know, your group is considered. So let's move to the next slide and we'll talk about the specific groups. So, so think about your role in the system. So are you an advocate? Are you a disability rights attorney? Are you a funder? And think about those kind of your role in the system, and then think about when your group meets. So for example, if you belong to a provider organization, an IDD provider organization, and you meet every month, you know, Fridays at 10 o'clock, that's an ideal time if you have standing meetings to invite us to that meeting to do the focus group. It's just an easy way. You don't have to necessarily set up a separate meeting, as you just kind of put us on the agenda. The groups take about an hour. And we want to make sure that the groups are representative of different elements within the system. So this is the chance for your kind of stakeholder group in the system to have input. So it's really important if you belong to one of these groups to reach out. Next slide. And here's just examples of some of the groups that we typically like to do. We like to do some with family caregivers, mental health providers, and just a note on these is the groups can be done in a variety of languages. We just need some advance notice for all of that. And we will also schedule groups, for example, with family caregivers at times that are convenient for those folks to meet. So, you know, we've done some during lunch hours or at 6 o'clock at night. We want to make sure that we're being as accessible as possible to the groups on this list.
And because,
and this is not
because
a
of the
comprehensive list. So if you don't see your, you know, your kind of stakeholder group on this, that's okay. Just reach out to me. This is just kind of some groups to consider. It's definitely not comprehensive.
So what I was going to say, Anne, is because of the geography in Maine, all of these will be held in Zoom.
Yes, yes. That is an excellent point. Is one of the, you know, kind of benefits of doing this via Zoom is that we can get people from all over the state of Maine, because it is very important that we're looking at service availability, not just in the center of Maine, in Portland or Augusta, but, up in Aroostook County or, wherever people live. So yes, thank you. Next slide. I mentioned earlier the family caregiver interviews. So we use a validated interview tool for family caregivers. And the focus of the interview is family experiences with the mental health system. So we're going to ask specific questions about how their experience with mental health services have gone. We have a team of trained interviewers, and we will arrange times with families. Again, we can do interviews in English and Spanish quite easily, and other languages as needed. We just, have to know about those. One of the things that is really important to know is that prior to beginning any family interviews, I will work with Betsy and Miranda to make sure that in the event that we are interviewing a family who is in immediate need, has an immediate crisis or is an emergent need of help, that we have a referral for them. So that, we'd never want to call up a family and say, oh, thanks for, sharing your experiences. I'm sorry you're in crisis. Good luck to you. We would never want to do that. So I think that's just important to know that we do have a crisis referral protocol as part of this interview process. And, we always would close the loop on that with Betsy. And then again, the interview, it's a mixed qualitative and quantitative. So most of them are survey questions where the family gives a specific answer on a scale, but there's 2 open-ended questions about mental health services that the family member needed that were not available, and then advice that the family would give to service planners regarding mental health services. Next slide.
So it isn't just mental health services, it's any service. So if you go back to the last slide, the question is, was there any particular service that your family member needed that was not available? We will all often hear about dentistry, for example, which is not a mental health service, but it's a service that a lot of people with disabilities have poor access to. So that's very open-ended. This is where we might even get feedback about vocational services, support to families. There's lots of, this is the one question where people actually just tell us about their service needs. Is that correct, Anne? Am I right about that?
Yes, that is. Thank you for clarifying.
That's all right.
The interview questions focus on mental health services, but the open questions are exactly as they're written there. So yes, we get a lot of feedback about dental services or lack of availability of dental services. Yes, thank you for clarifying.
No problem.
Next slide. So your role in the FEIS. So this is, you have a large role in this part of the evaluation is, we can reach out directly to all of you and say, hey, you want to do a focus group? We cannot reach out to any families directly. We don't have their information. So we need you to invite families to participate. We can't access them. So I really encourage you, if you, to be creative with families. Some people have a Facebook group for families where they'll post, hey, want to participate in this, email Ann Klein at University of New Hampshire. You can send out emails to families if you have a listserv or a mailing list and invite them to participate. We've had providers who have just done sign-up sheets in their office and saying, hey, if you're interested in this, sign up. And then once a family has signed up, they've given them permission for that information to be shared. So as you reach out to families, then they're invited to contact us. And then once they contact us, we set them up with an interviewer from our team. So this is a very important role, and one of the hardest aspects of this evaluation is making sure that we get families, and that we get families again from across the state. So, think about the families you support and who might be interested. Our experience has been that families enjoy the interview process and are really happy to share information with us. So next slide. So here is just a kind of a brief project timeline. The plan is to begin data collection in early May. It'll probably be the second week of May when the survey link will go live. And then we'll collect data for a couple of months. We're going to collect data a little bit longer just because it's over the summer. And then we will begin an analysis of that data in July, and hope to have a report back to OADS for review. We'll make sure that that report is in plain language and accessible to stakeholders. And then at some point, as Dr. Beasley mentioned, we hopefully will be able to get together as a larger group and present all of the findings and recommendations to all of you who are here today. Next slide. Okay, so
and we have a question. I'm just gonna so we have a couple of questions. So will we the first step is, okay, I just said that. Will you also be conducting interviews directly with people? Yes. The answer is yes. No, in focus groups. So we will not be doing individual interviews. We do not have a formal tool, a validated tool. But Stacy, I'm glad you asked, because the Center for Start Services got a grant and we're developing that as we speak. And hopefully in the coming years, months and years, we will have something called the Person Experiences Interview Schedule. There is nothing like that that we could find in the literature to really evaluate their mental health service needs. So right now we're a little relying on families and focus groups, but that will be coming in the future. Is this going to be information that once gathered and evaluated to inform the system of care in Maine? Yes, that's the idea, Hillary, that we will be informing the system of care. That's it. And collaborating with you about what to do with this information. Like, what does it mean to you? What would you like to see happen going forward? And to kind of give some examples of things that we know can work and that we have from other states and from the START model. How long does a family interview generally take? 20 minutes. Is that correct, Anne? Many of our families express limited availability due to a number of factors. I'm sure those that are interested will ask. So, Anne, in Wisconsin, how many family interviews have we been able to conduct?
So we typically aim for 30, and in Wisconsin, I think we did 35 or 36. I believe in Maine, we are also budgeted for 30. They take about 20 minutes. And again, we have a team of interviewers, and we will do interviews at times that are convenient with the family. So once a family contacts us and said, hey, I'd like to participate, usually that's an email, sometimes they call me, but they say, hey, I'd like to do this interview. I connect them with one of our, somebody on our team who does the interviewers, and they set up a time that's mutually beneficial. So they say, oh, I can do it, at night after the kids are in bed, or I can do it right after the kids go to school in the morning, or I can do it, on my drive home. And we will set up the interview times based on family availability. They absolutely do not need to be done during, business hours.
And the other thing to know is, the reason why I bring up Wisconsin is we're working with Wisconsin now, and Wisconsin has urban settings and a lot of rural locations, very, very much. I mean, Wisconsin isn't exactly like Maine, but in the way people are dispersed, it's similar. How many people responded to the survey in Wisconsin, Anne?
About 1,200.
1,200. So if it sounds to me that the citizens of Maine are very interested in change in Maine. And so what we need from the people here is really important. It's very, very important to think about what that looks like for Maine and engage people in knowing that this will affect change. We're not just asking them for the sake of asking them. We're asking them to make a plan. And this is their opportunity to help make a plan. And if we ask them in that way, a lot of people do participate. So another question, why not include 3 to 6 year olds in the research who are receiving services and maybe in special purpose preschools, especially the ones with IDD or MH diagnosis? Because we don't really get involved in early education and preschool. We only get involved school age and up. It's just not something that we have expertise in. It's not an area that the Center for Start Services covers. Certainly, because we start at age 6, we do include understanding the needs of young children. And when we ask the questions of families and we ask about services, we ask about children's services and adult services. And we do not put an age limit on our questions about children's services. So we don't say children's services for children ages 6 and older. We ask about children's services in general. So that might help to answer the question. Will there be resources set aside to foster implementation of the findings for improvements? That is a Betsy question.
Yes, and so many of you have heard us talk about the increase in federal funding that ODES has right now. We call them 9817 FMAP funds. And when we put our initial plan up for how we're going to spend these grant funds, we included funding to implement some of the recommendations, depending on what they are coming out of this evaluation. So we have set aside some of those grant funds, and we always have the opportunity to go back and seek more funds if we need. So we're really looking forward to as Dr. Beasley and Ann are talking with getting the results and getting the recommendations so that we can then try to move ahead with pilots or implementing as many of the recommendations as we can.
So one of the things that, and then I'll let Ann finish this, any particular topical areas off limits in this analysis? I don't know, Todd. You'd have to give me one and I'd have to tell you whether it's off limits. I have no idea. As part of the data collection, such as looking at claims usage, will data be collected on number of current out-of-state placements? Yes. Single developments? Yes. ER? Yes. Very good. Allie, come join our team. As a healthcare giver, we are very interested in change that will support not only the patient, but the staff caring for them. Agreed 100%. So a lot of our questions, Rose, are about training and capacity building. So for example, we've had a recent experience in Maine where some of the people couldn't be trained because they didn't have time to get trained. And that's something we're going to have to talk about in terms of system change. How do we build capacity if we're so under-resourced that people don't have the time to learn how to improve their capacity? And this is a challenge that Betsy knows that we face in Maine and that we're going to try to work together to compensate for. Some of the things that we will talk about in our action planning with regard to training is how you can provide training that's more accessible to people who actually have to work most of the time and don't have time for like a day-long conference or 4 hours of training a week or something like that. So we will try to cover that. Good question, Rose.
One more question that came in the Q&A section. When we're talking about families, we do talk to families, family members. They do not have to have their family member living with them. I think that's what the question is. So as long as they're, have insight and involvement in the care and want to weigh in, yes, absolutely. Some of the families that we will interview do not necessarily have their family member living with them, and the same with focus groups. They just
But they have to be the primary informant, though. So they can't be,
Yeah.
so they can't just be like somebody's cousin who feels like they want to talk about them, but don't really spend a lot of time or know what's going on. So it's not any family. They have to be a family caregiver. And actually, even if they're living with the person, it has to be the person who is the most engaged in the person's mental health services. So that is not always the person you think it is. And so we have to, we dig down to try to identify that.
Yeah, one of the questions is, do you attend mental health appointments with your family members? So that is kind of the, that's kind of the dividing when we talk about family. So just a couple of kind of what's next, and then we'll continue to answer any questions that come in. Following today, I'm going to get the list of emails of everyone who was on this call today from Miranda, and I will set up an email contact using those, and that's how we'll communicate. So one of the first things that you will get is just a copy of the online survey, and just to kind of review, and particularly we want any feedback on the names of the services that are listed in that document. So for example, if there's self-directed support, are we using the right name, so that when we're referencing those services, people in Maine know what we're talking about. And different services have different names in different states, and we want to make sure that we're using the names that apply to Maine. So that's one of the things that we'll ask you to do. It would be very helpful, even though I will get your email addresses from Miranda, if you complete the little survey that just says, are you interested in being part of a focus group? Because I will be reaching out to you to say, hey, what is your group? When do you meet? And when can I come and talk to you? Or when can one of our staff come and meet with you? And then it also asks about kind of access to families, just so I have some idea, who can I reach out to say, are we inviting families to participate in this process? And then the survey link will likely go live. My kind of go-to date right now is the beginning of the second week in May, so the beginning of that week. So that gives us a little bit of time to put together the distribution list, gives us a little bit of time to make sure that the language in the survey is relevant to Maine, and gets a little bit of time to set up the link itself to the online survey. And then once the survey is live, then I'll also at that point start reaching out to folks to get information for focus groups and family interviews. So that's kind of, in a nutshell, the next step. And that is the end of, I believe that was the last slide. So that's the end of kind of the formal presentation, but we are happy to continue to answer any questions that you all have.
So there's one philosophical premise that we at this National Center have that I think we share with Betsy, who, by the way, has been very aggressive about making sure we do this. I think she would testify that we had some early contracting problems, and I was like, well, we've got 5 other states involved, and Betsy was like, but it's Maine. So we were able to move things around and get Maine in as soon as we could. So we're very happy to be engaged and working with Betsy, especially in this process. So thank you for the opportunity, Betsy. And the one thing that I think we share in common is that there's a quote by Maya Angelou, and this is the one that we really try to focus on. We're not here to target anyone, to say, oh my God, look how terrible we are. look how horrible it's been, but rather we're going to do the best we can until we know better. And when we know better, we need to do better. So this information requires that we make no more excuses. Once we know what the problem is, we have to develop a strategy to do better. And that's really what is required by this work in order for it to be meaningful. And the other quote that I like to use is by Malcolm X, who I'm paraphrasing here, but he said, don't be so, don't be so aggressive toward people who don't know what you know now. You didn't know what you know now until you knew it today. In other words, we are not here to say, whoever we find out needs more support in doing better. We're not here to lay blame. We're here to collaborate and be constructive and move forward to make things better. But the most important thing is we're asking families and individuals with lived experiences, service providers, and all of you to take the time and effort to be brave and tell us what's going on. And we need to be respectful of that and have a product that comes from this, that it's not just a conversation, but the beginning of implementation. So that's very important. And hello to Ann's daughter, who is apparently home from school.
Thank you, Joan, really appreciate that. And I do have one question because I got it actually before we started. And I'll just say that I've had a lot of conversations about this work coming to Maine, and people are really happy to have you here and working with us. And I really do feel like our so many people here in Maine are on board with helping us try to figure out and come up with some solutions to some issues that we know we have here. One of those is I've already had a couple of groups reach out about wanting to have a focus group meeting attached to one of their meetings. So should they go ahead and email that to Miranda if that's an interest and a date, or Anne, or how would you like them?
I would say both. So yeah, email them both.
Okay.
So Anne and CC Miranda, or Miranda and CC Anne. I don't think there's anything wrong with having it be simultaneous. In fact, that is the best way to do focus groups. If you have regularly scheduled meetings, it's very easy to drop into those meetings and have a focus group. It's an excellent idea. Excellent.
I'm looking at one of the questions on the Q&A. So for proposed how focus groups will be connected, just like Dr. Beasley just mentioned, if you are interested in a focus group, just shoot me an email and then we'll talk about when your group meets. For people with lived experiences, we've done this a couple of different ways. I almost always try to go if there's a People First or self-advocacy organization in the state of Maine. I always try to connect with them and see if they'll invite me to one of their meetings, and they almost always do. The other thing that we have done for both families and people with lived experiences is we've just set up a couple of groups and then sent out invitations to people so that we can try to reach people who maybe aren't part of that specific organization. Does that answer the question?
I'll just offer too, Jay, if you have a group that you're recommending there, then you can certainly also reach out to Miranda, and she can help sort of broker, something as well, if that's easier.
Yeah, everything should go to Anne and Miranda, or just Miranda, but never just Anne, because we work for Miranda. So, I mean, that's basically, to make a long story short.
And it looks like Jay would like to talk, so I'm going to allow Jay to unmute right now.
Yeah, I just realized, because that way I can really quickly make sure that what I understood addresses both Bessie's question to me and Anne's response. The two groups I'm thinking of, not every single member would be relevant. For example, one group has been meeting online for a while, so a regular participant is from Connecticut. So I was trying to figure out where certain members of a group together, or two groups together, would make up a focus group. Can that be coordinated?
Yes, and so basically what
But
you
follow the
do,
same process.
yeah. So what
Got
you would do, Jay, would be you'd have like on the agenda, you would say main focus group, and you'd split off that part of the meeting to just include the people from Maine who are interested in being in the focus group.
Got it.
Yep,
Thanks.
you're welcome. Good question. Well, I can't believe we're getting started, Betsy. I don't know.
I know. Looks like Bonnie has a question there for
Okay.
you all too on the chat. Some recommendations that you made from past experiences. And then she's just saying they're pleased to have you here to help us improve supports for people.
So I'm gonna give you two that did not include START, because one of the things that's very important to me and to Anne is that you don't see us as like salespeople for the START model. Betsy knows this. We work for the state of New Hampshire through the University of New Hampshire. We don't get paid any more money for 10 projects or 12 projects. It's not a personal gain thing here. We're not trying to sell something. So in the state of Georgia, which is the homeland of Olmsted, they had built an infrastructure that was not doing well, despite lots of money and resources going in, Department of Justice oversight and the like. And really what it was about was they didn't really have a clear avenue toward a community of practice and toward really integrating the services through training and collaboration. And so our focus, we did a systems analysis to see whether the START model could help. And we felt they already had so many things in place that it made no sense to duplicate that. And so what we recommended was quite a bit of training to kind of bring the system together. We also did that with the state of Hawaii. The state of Hawaii is not set up to have a START program because of the various islands, and we'd have to have crisis clinicians flying from island to island. And also if you live in Hawaii, I don't understand how you could be in crisis, but that's just a little sidebar from somebody in Massachusetts. But so we focus more on training and capacity building, and also looking at the system of care and ensuring that the infrastructure had all the pieces. In Indiana, they had a model that they had already developed. What we were able to do through the claims data analysis, and how many people did they have to stop serving one-to-one to create a crisis system in Indiana? I think it was 10%.
Yeah, I think it was 10%. It was a long time ago, but that's the number that sticks in my mind.
If they stopped giving people one-to-one and isolated staffing and managing them, and they never got better by 10%, they would have been able to have the resources that they needed through the waiver to develop and implement a much better practice. And so that was our recommendation there. It was really about helping them find resources to move forward. In many states, it's about development of START. In New York State, we had to evaluate every region in New York, one region at a time, to make sure the START model fit with that region. So there's lots of different. California, we did a state, we're in 15 regions in the state of California. It's like being in 15 nation states. So each time you have to really look at the system of care. The system analysis, go ahead.
Oh, I was just going to go back. There's been a couple questions about focus groups. So I just want to clarify a couple things with focus groups. So the focus group topics are always the same. So we focus on how well the system is doing. So what's working, what's not working, and then what recommendations people would make. So what's different is the perspective of the people in the focus group. So questions are always the same for every group, but we're asking from the perspective of people with lived experiences, from the perspective of family members, from the perspective of IDD providers, from the perspective of psychiatrists. So that's what's different about the focus groups. And the focus groups are limited to an hour. So I have done them in 45 minutes when I'm trying to fit into an existing meeting schedule, but we do not go over an hour.
And yes, we will have a children's mental health focus group and an adult mental health focus group. So there's a lot of
Okay.
questions about children. And so, yes, we will separate that out. So because it sounds like your system is very bifurcated in this way, we will make sure to do that. That's the kind of, so we're getting a lot of questions in about children and making sure their needs are addressed. We can certainly do that.
There's a fairly lengthy question in the Q&A. I don't know if you want me to read it or if we want to
Sure.
hear Diana. Okay. As a provider, I noticed that parents take their children to doctor's offices and provide information to the doctor, PCP specialists, etc. This information from home isn't always relevant in school and community settings. So issues that are based on caregiver skills, deficits, or environmental triggers aren't always taken into consideration. Diagnoses are made without all the information necessary. How can we ensure that healthcare providers are getting all the information they need to make educated decisions on diagnoses and medications?
So that is a very complicated question. It's nothing to do with what we're doing. It's a whole training in itself. But let me just say, I never think that what the family member is telling the doctor is irrelevant. So I would argue that that is not the whole picture. And one of the things that we know for sure is that the way physicians prescribe, diagnose, and prescribe is rarely a whole person approach. It's more symptom management than it is diagnosis and treatment formulation in the way that we just described. One of the things we'll hear in terms of the survey and the focus groups is to what degree is that a problem? And then one of the remedies might be, how do we address that problem by helping to teach the family or the school or the system of care as a whole to better communicate so that the physician or prescriber has all the information that they need. Some of this is driven by the prescriber. I urge you to go on the website, on our website. We've just developed a prescriber's guide in Iddmh, which was researched, and we're now training interns and residents at Dartmouth Medical School using the guide, which will then the training and the guide will be widely available. The guide is currently available for free. It's on the and can you give them the link to our website? And that might be helpful because some of it is whether or not the prescriber is paying attention to the issues that you're talking about. So if they're not asking how things are in school or getting that information about the school setting, they're not going to know what's going on. So it's a complicated question. Everybody has something to learn and everybody has something to contribute.
There's another question about sometimes with surveys, we find it hard to get individuals and families to continue to provide important input as they feel frustrated that their input isn't going to be implemented. And they are sometimes in this system asked to participate in a lot of ongoing surveys.
Yep.
Her question, how will this information after it is collected be shared back with people that provide the feedback as well as next steps on plans to implement the
So
recommendations?
we really would love for people, so when they participate in the survey or the focus group, they are asked would they like a copy of the report. And we will send them the report if they want it. Because it's anonymous, the surveys are anonymous, it's very difficult. So they have to be able to sign up to get a copy of the report separate from the survey itself. So what we'll do is put a link in there and make sure that they have access to the report that comes from the information they give us. Because I agree, they are giving us information and they want to see, is there information like everybody else's? Are the outcomes, what is going to happen with this? Hence the fact that we are going to make sure the report is accessible and in plain language so that it is available to everyone and accessible to all. But nothing gets published without the approval of the department. Just to be clear, it all goes to the department approves it, and then it's distributed based on the approval of the department. What we develop originally is a draft, and the draft has to be approved in order for it to be an official report.
And our plan just at the final meeting that Joan and Ann discussed is to share those recommendations and then talk about the next steps of the implementation plan.
Right, and we'll have a PowerPoint that gives sort of a snap, a simple view of what we've done and what we've learned and what the recommendations are. We also, if you want, Betsy, we write an executive summary for the report, which is sort of a one-page thing, because legislators, this is being recorded, but they don't like to read. So what they like is like one page, that's enough for them. So we will do that too.
I think an executive summary would be helpful to have, sure. Thank you. Somebody's asking about whether or not we're planning to connect to the developmental pediatric community and pediatrics
Yes.
in general.
Yep.
Okay.
So basically, what you need to do is let Miranda know what focus groups you think are important and make sure it gets on the list. That's all you have to do.
There is a question, this is Miranda, that came in through the chat regarding scheduling and links for the different focus groups. Can you speak to a little bit to how that will work?
So the focus groups are really sort of set up by invitation. So the way, so let me give you an example is, I recently met with a group of outpatient psychiatrists, and the way that worked is I connected with one psychiatrist who was on a call similar to this, and then she forwarded it to her colleagues and said, hey, come to a focus group that's going to be focused on outpatient psychiatry. So it isn't like a published link, it gets emailed to people who are invited. So if you are, again, a provider organization, and you say, hey, we set up a focus group so we can all weigh in, then that, you know, I would provide a link to that group, and then that would go out to your organization or anyone that you want to invite. So does that kind of clarify how the focus groups work?
Can you share, Anne, what's the general number of people in a focus group that you tend to have that's a good number to think about?
They tend to be 8 to 10 people. We can do a little bit larger, but over Zoom that it gets unwieldy if it's, you know, over 12 or 13. So 8 to 10 is an ideal number. I have to say, with some groups in particular, when I meet with, you know, I've met with judges or law enforcement, those tend to be smaller. It's just hard to get, sometimes it's hard to get those, they don't have standing meetings, so it's hard to get a bunch of people at the same time. So, you know, I did one recently where we just invited several sheriffs from across the state, so in various regions of the state, to come to a group, and I think there were 4 or 5, and that was fine. But yeah, 8 to 10 is ideal.
Right.
And if we had to, let's say by some miracle, we had 16 people sign up, we would break the focus group into 2 breakouts during the Zoom and just add a second interviewer. So we can accommodate it. We just need to know the numbers in advance.
So there is a question about if you will connect with law enforcement, and I just heard that example. So the answer
Oh,
is
yeah.
And then our 3 psychiatric hospitals.
Yep.
We always try our best to do law enforcement, and absolutely, if there are psychiatric hospitals, you know, once I get in touch with one of them, they usually know the people at the other ones who are their counterparts. And so, yes, you know, I will use all of the contact information that you've provided to Miranda, or that you've provided on the link, to try to set up those groups. Emergency departments are very, very tough. That I have never done a focus group with emergency department personnel. What I have done is the workers.
Yeah.
So the folks that when
Yeah.
somebody is in the emergency room, they're the folks trying to get them out of the emergency room. But so emergency departments, I have never done one with,
Yeah,
like
I think we do have some interest from some of our hospitals that we've been engaged with for sure, who I think would be interested in probably putting together a focus group of people who could answer questions across the board around, kind of what's happening in the hospitals and that kind of thing. So, but I know that we'll try to probably work with them to put together, they're interested in a focus group.
And we'd love to do it, but yeah.
They would probably be included in first responders. We don't get that many first responders, but a lot of the first responders are EMTs, people who respond from the emergency department.
Sure.
So we do have a first responders focus group. We do not have unlimited resources for focus groups. So sometimes they'll have to be combined, but they have the same mission, but they will self-identify. So we'll know which level of identification fits with which member of the focus group.
And Miranda and Betsy, once we start scheduling focus groups, I'll make sure that you have sort of a list of the focus groups that are scheduled and then who on the list is kind of missing, so we can make sure we target those. But yeah, we have a certain number that we're kind of scheduled to do.
And Anne gets tempted to exceed it, but she cannot. So that's it. And
well, I mean, and I will just say that we can help, make connections for people to get involved in a focus group if needed too, if that's helpful. I don't know.
so people are listing all the people they want to hear from. Remember, the survey is very comprehensive and people will identify what their role is on the survey. And some of these people are kind of busy, like mobile crisis workers, and they would do better responding to a survey, although we will have a focus group if we can with first responders. We will get their input through the survey. So don't forget, we have 3 methods. Focus groups is the least practical method. Let me say this again. Focus groups is the least practical method because it means that people have to sit on Zoom for an hour and participate in a group, which a lot of people don't have time to do, or they don't have the same time that other people have. So it's hard to line it up. So we do focus groups as one element of our qualitative study, but we also have a very comprehensive survey, which is why the state of Wisconsin had 1,200 people respond. Many of them worked in emergency rooms and other places which didn't have a voice before in helping with policy planning. So don't forget the surveys.
Great.
So the PNA will have its own focus group. We always offer that. Whoever said, I'm sure Maine's PNA would be interested in connecting. Thanks.
Yeah, I don't think we've ever done an evaluation without having.
They always want their own focus group.
Right.
We always give it to them.
Good. Well, I don't see any other questions at this.
A question just came in through the Q&A. This is Miranda. Todd Goodwin is asking, would participants ever know of recommendations rejected by the state in its review of the draft report prior to public distribution?
No. Not from us, because we work for the state. And it's not a public document until it's an official report. So if it's in draft, then only the state will know what the recommendations are that they rejected. That's unless there's another way of discussing this, Betsy. I mean, I just,
Oh, I think you're right. All right. Well, thanks again to you both for joining us, and thanks for those of you who've hung on the line with your great questions. And Miranda will be our connection in Maine for sure going forward. And as soon as we get that survey, we'll make sure we forward it along to all of the groups that we're aware of on our end too. Really looking forward to working with you both on this
Thank you.
exciting project.
thank you. I spend every summer in Southwest Harbor, so Maine is very important to me.
Yes.
So thank you all very much. It's a pleasure and an honor to be a part of this project with all of you. So we look forward to it. And Anne's family is from Maine, so we're very Maine connected.
Oh, good.
Okay, thank you. All right, bye.
Take care.
Bye.
Thank you, everyone.
Thank you.